Hey, good day and good evening, everyone. I hope you can all hear me. Please just let me know in the chat section if everything works fine. I will appreciate the information from you. We are here today on our next IVF webinars. I'm Sophie and I will be your host today. It's a pleasure to have you all here again. We are meeting here every Tuesday and it's our 51st webinar already. And today we are here with Dr. Ruth Sánchez, gynaecologist at PreGen, the reproduction unit of Clínica Vistahermosa. And we will be talking about endometriosis. How does an endometriosis affect IVF success rates and what can be done with it? Presentation will take about 20 minutes, and right after that we will follow with the Q&A session. So type your question in the chat section and we will ask them one by one. Okay, from my side, that's all. I just remind you that the webinar is being recorded and it will be available on our website. I put the link in the chat section as well. Dr. Ruth, are you ready? We can start. Yes, hi, welcome.
Hi.
So fingers crossed and let's do it.
Okay, now, good evening for everyone and from Alicante. Now, as you said, the theme of the webinar is how endometriosis affects success rates and what to do. So, well, let's begin with the definition of this disease. Endometriosis is a benign and chronic disease that affects the woman. That means that the endometrial tissue from the inner of the uterus is outside this organ. The frequency of this disease is in women on reproductive age between 6 and 10%. If we talk about women with fertility problems, we have between 25 and 50%. And we have to know that if we take the women with endometriosis, almost half of these patients will present infertility in any time of their life. The locations of the endometriosis depends on whether this endometrial tissue grow. The most frequent locations are in the ovaries, usually as cysts, and in the tubes. But also we can see implants in the surface of the uterus, in the wall of the uterus, in the ligaments from the uterus, the uterosacral, in the bladder, in the abdominal wall, in the bowels, and even we can find endometriosis in the lung. Depending on the locations, when the women have the menstruations, they can have pain in each location. Even they can have urine with blood and pleural effusion in the case of the chest location. Okay, but not all endometriosis is the same. There are several stages. We have the stage 1 is a minimal endometriosis. This is this picture when we can find sporadic surface implants, and most of the times in these cases, the endometriosis is asymptomatic. The second stage is a mild one, and we can find one or more implants that can penetrate deeper into the wall of the uterus, and we find the implants also in the uterosacral ligaments. These two stages are the most frequent. We have a third stage that is a moderate one, in which we can find many deep implants in the uterus, small cysts in one or both ovaries, and we begin to find thin adhesions of the abdominal cavity. The fourth stage is the severe one, we find many deep implants, cysts in both ovaries, and very firm adhesions between organs. Okay, what about the symptoms? Now, almost half of the patients with endometriosis are asymptomatic because the most frequent stages are the stage 1 and stage 2. When we find symptoms, the most frequent one is pain, like abdominal pain, dysmenorrhea is pain with the menstruation, or even pain during sexual intercourse. We also find infertility in half of the patients with endometriosis, as I said before. And depending on the locations of the implants, we can also find dysuria, that is pain with the miction. Hematuria is blood in the urine. Even pain when defecating, or rectal bleeding if we have implants in the bowels. And in the rare case of implants in the chest, we can find chest pain and pleural effusion with the menstruations. These symptoms are more intense during the menstruations, and they improve in the menopause and in pregnancy. These are periods in which there are no menstruations. Okay, but why this disease causes infertility? Well, in the ovary, that is the most frequent location, it reduces the ovarian reserve because it destroys the healthy tissue of the ovary. It also hinders the normal development of the follicle, so it makes an abnormal development and maturation of the oocytes. That makes that the ovulation is not normal. If it affects the tubes, it makes difficult in transport of the oocytes and difficult in transport of the sperm because of the adhesions that it causes in the tubes. It's frequent to see the tubes obstructed. Sorry. So in the endometrium, it also affects because it makes an alteration of the immune system, so it decreases the endometrial receptivity and the capacity of implantation. In all the locations, there are toxic substances that they are dangerous for the embryo and for the sperm and also the oocytes. So all the environment in the endometriosis is not good for the implantation and for the fecundation. And how can we diagnose this disease? Well, it's very important to do a very good clinic history. We have to ask for personal history to find the risk factors of this disease. Some of them are nulliparity, to have an early first menstruations, to have heavy bleeding and short cycles, to have low body mass index, to drink alcohol. It's also a risk factor to have a history of gynecological or obstetric surgery. Also, a high sociocultural level is a risk factor for endometriosis, and do exercise, it can prevent the endometriosis. It's also important to ask for family history, because if there is a family component. If the patient have a first degree relative with endometriosis, she has between 7 and 10 times more likely, or she is more likely to have endometriosis itself. So it is very important to do a very good interview looking for this information. So next, we have to do a physical examination, but we have to know that in most cases, the examination is going to be normal. we cannot find anything in a physical examination. If we find something, we can find with an speculoscopy. We can see cervical or sac bottom endometriosis like brown or bluish nodules. In the vaginal touch, we usually find the uterus in retroversion, fixed and very painful when we mobilize it. We also can find painful and irregular innervations in the uterosacral ligaments and in vaginal septum. And we can also find large ovaries and the ovaries fixed to the posterior uterine wall. The first technique that we have to use is the transvaginal ultrasound. In the transvaginal ultrasound, we are not going to find the small implants of the endometriosis. What we can see is the cysts in the ovaries. So it's the first technique to do to find these cysts. And the cysts in the ovaries, the endometriosis cysts, have a very typical image. It's like this one you can see in this picture. The magnetic resonance image we can do it only in selected cases, not for routine. We can ask for this technique when we have a suspicion of uterosacral or vaginal or pelvic implants, and we cannot see it with other techniques. And the laparoscopy or laparotomy, they give us the confirmation diagnosis because they allow us to see the cavity and to see the implants, like you see in this image. These brown pieces are implants of endometriosis in the wall of the bladder. So we make a laparoscopy, we can take a biopsy of these implants and have an anatomopathological study to confirm this. Okay. Oh, it has moved the letters. Okay. What about the treatments? First of all, we have to inform the patient that the endometriosis has no cure. As I said before, it is a chronic disease that has no cure. It improves in the menopause, but during the fertile age, we have no cure for it. So the therapeutic approach will depend on if we want to treat the pain or we want to treat the infertility. If we want to treat the pain, our first option is the hormone therapies, like the contraception pill, in order to prevent a heavy bleeding with the menstruation, and it can relieve the pain. We can also do radical surgery because it decreases symptoms and improves life quality. So we suggest radical surgery if to patients that have a lot of pain and live with pain every day. So it can improve their life quality. But they have to be informed that in half of the cases in the next 5 years, they can have recurrences. And if we make another surgery, we are lowering their ovarian reserve. If we are talking about treating infertility, well, the main goal of this treatment is to preserve the ovarian function. Sorry, with my pronunciation. Okay, the surgery, it is demonstrated that if we do surgery to remove lesions larger than 4 centimeters, we improve spontaneous pregnancy rates, but not in IVF. So the current trend in endometriosis and fertility is to do no surgery and to do an early fertility treatment. When we do indicate surgery previous to an IVF, well, we can do a surgery And in women with preserved ovarian reserve, so we are talking about young women with a good anti-Mullerian hormone and a good ovarian reserve, in women with no previous surgery, who has only unilateral disease and who has a rapid growth of a cyst or a size larger than 5 centimeters. So in these cases, we can indicate surgery. But when do we go direct to IVF? Or why when do suggest to go direct to IVF? Oh, sorry. Well, in women with a decreased ovarian reserve, so in women with uh, more than 35, 38 years old, or who has an anti-Mullerian hormone very low, when in women with a disease recurrence, who has a previous surgery, on women with bilateral disease. In these cases, it's better to go direct to IVF because the pregnancy rates will not improve with the surgery, and only we are delaying the treatment. And what treatments, what treatments do we suggest are the best for people with endometriosis? Well, we have the intrauterine insemination, but it's not the first choice for these people. Only in patients with minimal or mild stages, in young women, because we have to know that this technique, the intrauterine insemination, has very low pregnancy rates. So only in a minimal stage in very young women we can decide to begin with insemination. The in vitro fertilization, the IVF, if our first choice. We have to inform to these people, these patients, that if they have severe endometriosis, the results will be worse. In fact, if we compare the results of IVF in patients with, for example, tubal factor, compared to IVF in patients with endometriosis, the results of the last one is worse than when the first one. We have to know and to inform these patients also that the results are worse because the endometriosis produce a decrease in the fertilization rate, in the implantation rate, and a decrease in the number of recovered ovocytes. It is demonstrated that if we give analogs during 3 or 6 months previous to the IVF, we can increase the pregnancy rates. So we suggest to give this medication previous to the treatment. A next step in the treatment, infertility treatment, is the egg donations. When can we offer this treatment? Well, in those women with a very, very low ovarian reserve after several surgeries, and that we cannot, their ovaries doesn't respond to the stimulation, it's impossible to get ovocytes, so they have to go to egg donations. Or even in patients with a good ovarian reserve, but with a very severe endometriosis with multiple adhesions in the pelvic cavity, that the ovaries are not reachable to do the oocyte retrieval. In these cases, we have to go to the egg donations. But as in medicine, the best is to prevent. So what we have to do is to inform the patients in the early stages of the disease, before this disease progresses, and to offer them the oocyte vitrifications before the ovarian reserve decreases too much. That can be a problem. So I think I have finished. Thank you, and I'm waiting for your questions. Sorry for my pronunciation, and if it's something that is not clear, I will be happy to tell you again.
Thank you, Dr. Ruth. Thank you. No problem. Thank you for the presentation. It was informative indeed. Now we will wait for the questions as somebody is typing already, and so please ask your question and type them in the chat section. It's the time for the questions. And here we go with the first question. I have adenomyosis. What can I do with it? Should I take a corticosteroid before IVF transfer or another medicines who can help for implantation of the embryo?
Okay, adenomyosis is another type of endometriosis that when it affects the wall of the uterus. So the treatment doesn't have good results, but in our clinic we advise to take analogs before the treatment because it improves the pregnancy rates and implantation rates. Almost 3 months previous to the treatment to take an injection, a monthly injection of analogs of the GnRH. Better than corticosteroids.
And thank you for explaining this. We have the next question, which is connected with this one. What exactly do you mean by analogs?
Okay, analogs is a medication, is analogs of the gonadotrophins. Well, the doctor should know this, the doctors, and this we give this to produce an amenorrhea to prevent the menstruations, to reduce the ovarian response. So, and we give it minimum for 3 months in order to reach the amenorrhea. And I don't know the names in your country. Okay, it provokes an artificial menopause because it blocks the hypophysis. It's a the hypophysis. Yes. I don't know the names of this medicine in your country.
Yes, of course, and thank you for explaining this and giving this additional information on the topic. We will take a look for the next question. I have severe endometriosis, 7 IVFs, 4 miscarriages, and 3 negative. Did egg donation first transfer, miscarriage second, healthy baby? Would love to try with own eggs again. Your medical opinion, please.
Well, if you have already had 7 IVF without success, I wouldn't advise to do an IVF with your own eggs again, because the probability of success is very, very low. So as I understand, your baby was with egg donation, and it's not a good option, I think.
Of course, thank you for the answer. I will take the next question for you, and this will be this one. I'm 47. I did 3 failed IVFs in UK. I did hysteroscopy to have a look to find out the endometriosis, sorry. I got very good quality blastocyst, but not implanted. What can I do to get pregnant now?
Well, I understand that the IVF were with your own eggs. It's amazing to have good blastocysts with this age. So in these cases, even if the embryos are of good morphological quality, they are probably genetical altered. So with 47 years old, we recommend egg donation.
Thank you. And now we will take a little different question, but still Important. I have 2 children and not planning to have more for now. My endometriosis is according to my doctor not operable, but I'm in pain. Is there any alternative treatment?
Yes, to relieve the pain, there are several treatments. The first one is the contraceptive pill, but there are also another treatments that can be good. Even the intrauterine device, Mirena, with levonorgestrel, that atrophy the endometrium inside the uterus and outside, and it relieve the pain very much. So you can ask your doctor, and he can give you more options, because there are, to relieve the pain there are several options.
Thank you for this answer and good news, I think. The next question is endometriosis an immunological disease?
Well, the etiopathogen of this disease is not clear. We don't really know the the cause of the endometriosis. There are multiple theories, so we cannot say that it's immunological.
Thank you. We will then take the next question. I have a low AMH and had surgery in January to remove endometriosis stage 3. Is there any chance my AMH levels could improve? Also, will the chance of implantation improve?
Well, after the surgery, the anti-Mullerian hormone is not going to improve. Uh, well, no, it's the opposite, because in the surgery, we try to be conservant, but we destroy healthy tissue of the ovary, so the anti-Mullerian hormone goes down. It can be the same or even less, but not improve. With the surgery, I have told that we can improve pregnancy rate, but only spontaneous pregnancy. But in IVF, it doesn't improve the pregnancy rate. So I understand that you have the surgery because it was a big cyst, and you had pain.
Actually, we don't have, I think, the additional information about this question, so I cannot tell you more or what was the reason of the surgery. So for now, we will take the next question, and this will be this one. About success rates. I have endometriosis and thinking about egg donation, very low AMH results. How comparing to patient without endometriosis may it influence overall success rates, implantation rates, etc. from your experience? In other words, would be an egg donation less successful for patient with endometriosis?
Well, as I told, the endometriosis affects in all the stages of the fertilization. The success rates are lower in patients with endometriosis, even in the egg donations, because it releases some toxic substances that can affect the embryo and the endometrial receptivity. But it depends on the stage of the endometriosis. It depends on if there are adenomyosis also. The endometriosis is a very big disease that can be very different patients with very different symptoms. So it depends on the severe of the endometriosis, but yes, it affects the pregnancy rates even in the egg donations because of the decrease in the endometrial receptivity.
Thank you for the question and your answer as well. And let's take a look for the next question. Is there a link between endometriosis and high natural killer cells, NK cells? I have a high NK cell count and also have endometriosis, so wondering if there is a link between the two.
Yes, probably there is a link, but it's not demonstrated because we don't know the origin of the disease. But as we said, it alters the system immune, so it can't be related with the higher natural killer cells. In these cases, we use corticosteroids to reduce the alteration of the immune system, but all these treatments are empirical. There is no studies that can certify the success of these treatments.
And thank you for explaining this also. The next question will be this one. Do you believe in Mediterranean diet or any other food to lower the pain?
Yes, I do believe in the Mediterranean diet, and I am very convinced that we are what we eat. So um, I think that the diet is very, very, very important, but we need more experience and more information. The clinicians should be more aware of this of the diet and the impact of the diet. But I'm not very informed of this, but I'm sure that it affects a lot and it can help with the pain and with the fertility. But in our clinic, we have people expert in this, and we have special diets for this for these people
Of
in
course.
the for people who are undertaking the fertility treatment.
Of course. Thank you for the explanation. And this one will be the next question for you. I had surgery to remove stage 3 endometriosis. Does this reduce the toxicity level and therefore improve the chance of implantation with egg donation?
Yes. If you do the treatment just after the surgery, it can improve the chance of implantation. If you wait to do the egg donation, as it has recurrence, perhaps you it can you will recover. Yes. So what we recommend is, if you are going to undergo a surgery, to do the fertility treatment just after the surgery, not to wait.
Thank you for answering this question and for the question, of course, as well. We will take the next question. I had nice blastocyst but not implanted in my 3 IVFs. Does mean my blastocyst have DNF defect?
Yes, to have nice blastocysts, if they are not genetic tested, we cannot say if they have defect or no. I don't know if you understand me. That you can have a very nice blastocyst, but it can be altered genetically. So with the age over 40, we recommend, if you are using your own eggs, is to do a genetic pregnancy as a pregnancy genetic diagnosis, a PGT, to the embryos to select the healthy ones.
Thank you for your answer, of course. And now we have the question, short one, but really important. Can endometriosis happen at any age?
Yes, but the most frequent age to appear is between 20 and 30 years old. But I have seen endometriosis in 50-year-old woman, but the period of more frequency is to 20 and 30 years.
Thank you for answering this question. And now we will take the more specific one, but of course, there may happen that it's not possible to answer this during this webinar. So I put also in the chat section our email, and if you have any questions which are alike, or if this question will not be answered to your specifically, we will forward everything to PreGen and Dr. Ruth, and I hope that they can provide you with answer more directly and more specific. And the question is, I want to start donor egg one next month, when I should start the first medication before I have donor egg program. I got period yesterday. If I want to start for next cycle, when I need to see you. So this is the question, I think, like overall, but if it's too specific, then as I told you, we will forward everything, and you can get more direct information. But this is the question.
Well, I think it's better that she contact us tomorrow morning, because it's when as I read, if I want to start on this cycle, when I need to see you. Okay, it depends on if we have some information of her or no, if you have an ultrasound scan before to see normally or no. Okay, we need the medical records to answer this question.
Exactly as I said. So in the chat section, there is also an email address. If you throw us an email and write your case, we will forward it tomorrow morning to PreGen and Dr. Ruth. So, okay, somebody is typing the question. I think that from the question which we had already, I asked every. Yes. So please, everyone, if you have any additional questions, type them in. It will be like a final call for questions. Yes, somebody is typing. We will just give a second and wait for the questions coming up. And here it is.
Okay. If anyone think and if any question later, they can write to us to the email, and we will be pleased to answer.
Yes, of course. We will also forward everything, so you will have all the information needed. And the question, next one for you is, I have a problem with my ovulation. Can it be because of endometriosis?
Well, it's difficult to say. There are a lot of problems with ovulation. I don't know if you don't have ovulation at all, or what kind of problem you have. Usually endometriosis causes more with pain than problems with the ovulation. It's difficult to confirm if it is because of the endometriosis.
Of course, I think that we don't have any additional information about this question. So thank you for the answer for now. If it appears, I will display it, but for now, I don't see any additional information. Someone is typing, so we will take a few seconds. We will be slowly finishing if the questions will not appear. So I encourage you to ask Dr. Ruth a question, as you have a great chance to do that. I did scratch in my uterus. Will that improve my implantation?
Yes, the scratch in the uterus improves the implantation because it improves the endometrial receptivity. It has nothing to do with endometriosis. We do it in the implantation failure. But as I said, with the steroids, there are no medical scientific studies that affirm that it improves. But empirically, we have very good results with this, so we do it in the implantation failures, independent of if the patient has endometriosis or no.
Thank you for the answer. this will be the final call for the questions. If anybody would like to ask one question more, we have still time to do that. If not, we then will be finishing. We have one more question more. Will scar tissue be good for adenomyosis?
This is a scratch.
Possibly scratch, yeah.
Well, as I answered with the question before, yes, the scratch is good for the endometrial receptivity, independent of the disease you have. For the adenomyosis, it works better to give the analogs, as I said before. And if we do the scratch, better, but we only do the scratch in the implantation failure. If you have adenomyosis with the first stage, the first intent, the first try, sorry, we don't do the scratch only for the adenomyosis. We do it for the implantation failure.
Thank you for explaining this. And we actually have two more questions more. How about if the person is on warfarin?
I understand warfarin is the medication for is an anticoagulation. So it is it is forbidden, contraindicated in pregnancy. So she should change to heparin. And if she's taking warfarin, it has a very high possibility of thrombosis. So all these treatments are at risk of thrombosis. So I would think of doing some of these treatments in a patient who needs warfarin. It can be dangerous, and in the pregnancy, it is forbidden. They have to change to heparin. So with the treatment for IVF or for egg donation, she should change warfarin to heparin also. But knowing that she has a high risk of thrombosis.
And thank you for giving this explanation to us. And we have also one more question, and this is it. Would you recommend assisted hatching?
Well, it does nothing to be with endometriosis. The assisted hatching is for the embryo, and it depends on the embryologist. It depends on the embryo. So they are the embryologists that decided if they do the assisted hatching or no. But it not depends on the disease of the patient. It depends on the development of the embryo.
Of course, and thank you for this answer as well. Okay, as I don't see any more question coming up, we will finish the webinar today, and I would like to thank you a lot, Dr. Ruth Sánchez and PreGen. It's a pleasure to have you here, and thank you for your presentation and for the answers you gave us. It was all very helpful. Of course, as I told you, it will be available tomorrow, the rewatch of our webinar. It will be available tomorrow on our website, but you can also follow us on our social media to be always up to date. Actually, Dr. Ruth, I have something for you. Thank you.
Oh, you're welcome.
This is a shout out from our audience, and thank you a lot for all the information you gave us today. If you have any final words to add, if you want to add anything, please do that now. If you want to say anything for the closure, you can do that now.
Now, just to say, it was a pleasure to explain this, to talk about endometriosis, because it's a very frequent disease, and almost everybody knows someone with endometriosis. And I hope you all have understood me because my English is very oxidated. So
Thank you a lot.
if you have understood, it's a success for me.
Thank you a lot. It was okay. No worries about that. Thank you for the presentation and for the answers as well. As I told you, the rewatch and also the transcription of the Q&A section will be available on our website. Rewatch tomorrow and Q&A section soon also. And one more information about upcoming webinar next week, same time, same place, and the next IVF webinars. Thank you, PreGen. Thank you, Dr. Ruth, everybody, for your attendance today and for your time. See you. See you next week. Good night. Bye.
Bye.